Aloha, and thank you for coming today for the second of 4 webinars about the new MedQuest Community Palliative Care Benefit. My name's Jeanette Kojane, and I'm the Executive Director of Kukuamau. Thanks to a grant from Hui Pohala, Kukuamau has organized this series with our wonderful speakers. And I really need to do a shout out to our team in the background who is making everything happen. So the first 3 webinars are for professionals and the final is for the public. We hope that you will help us spread the word about the webinar series and the new benefit. So today we're going to have 3 speakers, Judy Mohr Peterson, Dr. Toby Smith, and Torrie Fields. After the recorded presentations, there'll be a live Q&A sessions. So please be putting any questions you have as we go along into the Q&A. Thank you to everyone over the years who has worked on making this benefit a reality and helping us to be the first state in the country to be able to offer this to our people. So thank you again for coming, and we'll start the presentations now.
Hi, I'm Judy Mohr Peterson, MedQuest Administrator in Hawaii. Aloha, and thank you so much for attending this webinar series on the new Medicaid benefit for community palliative care. You know, we all want high quality care for ourselves and our family, especially when we have a serious illness. Unfortunately, we have a fragmented, confusing healthcare system. And the more complex your health and healthcare needs are, the more challenging it is. Navigating the healthcare system to get comprehensive, coordinated care can be extremely difficult. And community palliative care helps fill this gap and is the type of care we need for individuals with serious illness. It provides extra support from a multidisciplinary team that bridges all care settings, geographies, and cultures. It truly represents a whole person approach to care that we all value. For this reason, we at MedQuest recognized the need to make community palliative care a regular part of the Medicaid benefit. With the approval of the federal government, we were able to amend our state plan, and we're very proud to say that Hawaii is the first state in the nation to offer this. We're excited to present further details on community palliative care benefit throughout this webinar series. And on behalf of Hawaii's Quest members, mahalo for your help in making community palliative care more accessible for all of our communities across our islands. Mahalo.
Thank you very much for our next speaker. Toby Smith is a medical director for supportive care and medical management at HMSA. He is a geriatrician and a palliative care physician in skilled nursing facilities in Hawaii. Dr. Smith is ABIM board certified in geriatrics, hospice and palliative medicine, and internal medicine. Thank you, Toby.
Thank you, Jeanette. Appreciate it. So thank you, everyone, for joining us for this second webinar series on community palliative care benefit. I just wanted to start by saying thank you for everyone that has been involved with the development of this benefit here in Hawaii. I know it's been a long time coming, and I'm excited to see how this benefit ends up impacting our patients' lives here in Hawaii. And not only that, but just the unique opportunity that we have to set the stage for how this allows for significant changes for palliative care on a national level as well. So let's get into our agenda today. We're going to start with a brief review of the benefit basics, but not go into too much detail since this was addressed in the last webinar, and then head into talking about Roseanne's journey in palliative care and see how our current benefit essentially applies to her journey. After that, we'll discuss a little bit about the differences between what's already provided by Quest and what this palliative care benefit adds. We'll talk about what clinical services that are included and what access to those services looks like. We'll talk a little bit about the comprehensive clinical assessment that is done, and finish up by addressing the important aspect of care coordination. So again, who qualifies for this benefit? 2 essential criteria here that a patient needs to meet. First is that qualifying condition, and the second is evidence of functional or clinical decline. The list of qualifying conditions is quite a long list and encompasses a large number of disease processes. The thing to keep in mind here is that everyone could potentially have a medical condition that qualifies for palliative care. And realistically, we need to think about this for any of our patients that have any of these conditions, because it's not necessarily about if a patient qualifies, but when. And realistically, the next step is not too hard to determine. And this is to assess the clinical or functional impact of that condition. And that is where these assessment tools come in handy. There are 5 validated assessment tools that give thresholds for the severity or level of clinical progression. The KPS, ECOG, and PPS all give overall functional scores with threshold values that indicate the level of disability that someone would benefit from palliative care. The MELD score specific to liver disease, FAST score for Alzheimer's disease. But these tools aren't the only way to show that there is decline. And so other areas were developed that also have a high correlation to decline. Here's that list of durable medical equipment like oxygen or hospital bed that would meet criteria. And then there are clinical biomarkers of different disease processes such as ejection fraction, albumin level, etc. We also know that other comorbid conditions can contribute to disability, as well as the severity of the primary serious illness. Diabetes, coronary artery disease are just a few. And finally, healthcare utilization. This is in respect to hospitalizations, emergency department visits, skilled nursing facilities stays, just to name a few. And so big picture is that it is a combination of a qualifying condition and any one of these tools or aspects of functional or clinical decline to be enough for someone to qualify for palliative care. I think it's really important to understand that these conditions and tools really should be used early on, and that as a provider, performing an assessment early on will allow for a more proactive and preventative approach to helping take care of our patients with serious illness. So let's talk about someone with serious illness, in this case example, and see how this benefit might apply and play a pivotal role in her care. Roseanne is a 78-year-old female. She has pulmonary hypertension, valvular heart disease. She's also got osteoporosis, and she's been losing weight. She unfortunately is widowed, and about a year ago, she lost her husband who died of dementia, and she was a primary caregiver for her husband. Since then, she's been having feelings of isolation and anxiety. She's got 2 adopted sons, but they live on a neighbor island, and unfortunately, they don't visit very frequently. She did have a recent hospitalization for respiratory distress and was discharged home on some oxygen. Since then, she's been having some trouble with continued shortness of breath, anxiety with any sort of exertion, and her symptoms are primarily occurring at night. She's become more frustrated, especially with her decreased appetite, episodes of confusion, depression, and anxiety. She's concerned about losing her independence, and she's frequently calling 911 every time she gets short of breath. And so she sees her primary care provider. Fortunately, her primary care provider is able to see her and provide a clinical assessment and notes that her decline and medical conditions qualify her for palliative care. After talking with her, it seems like her 911 calls are often after hours, and there really isn't an opportunity to be seen in the office when she needs to be seen the most. There seems to be a lot more going on with her shortness of breath than just underlying heart disease and lung disease. So Roseanne's provider talks to her about having an additional set of providers involved with her care. Roseanne agrees, and her provider reaches out to a local palliative care agency who plan to visit her in her home. The palliative care provider ends up meeting Roseanne in her home and discusses her goals of care. The provider clarifies that her independence is what's most important to her. Her provider facilitates a virtual meeting call, which involves her primary care provider, in addition to her sons. And they all have a chance to address her concerns about independence as well as her shortness of breath. For Roseanne, there were several areas identified that the team could help support her in her ability to stay at home safely. This included getting physical therapy involved to help her with her strength and balance, determining that portable oxygen was something that was necessary to help her with her mobility in her home, and that education was needed to be provided regarding techniques to help maximize her lung function. Her medications were revised with a focus on making adjustments to improve her shortness of breath, her mood, and her appetite. Counseling was provided to help her understand and adjust to her serious illness. She was able to put a plan together to help better manage her symptoms in case she felt the need to call 911 or go to the ER. The plan was communicated with her primary medical team, who continued to be involved with her care. She was able to complete an advance directive as well as a pulse that was placed on her refrigerator. These are the things that might not have been addressed to this extent before and leading to an ongoing involvement of the palliative care team on a regular basis. By providing this ongoing involvement of the palliative care provider, nurse, social worker, grief counselor, Roseanne was able to experience less shortness of breath, anxiety, and had improvement in her appetite overall. She learned a better way to address her symptoms and had better access of who to call and when to call them for help. She was able to have more confidence and an improved quality of life as she resumed her activities at her senior center and her church. With the assistance of this team, she was able to reset her short and long-term goals of care as her needs changed, and her family and medical teams were kept involved. She was able to voice the things that meant the most to her, and they were able to honor her wishes. The team continued to meet and discuss her care plan every 2 weeks, in addition to involving her health plan on a monthly basis to assure that all potential support and resources could be provided. Collectively, all interventions that were put into place helped Roseanne avoid hospitalization as well as long-term nursing home placement, and ended up realizing the importance of having palliative care. Roseanne says, "Palliative care helped me live my life so that I wasn't struggling just to get through the day." The majority of Roseanne's story was taken from this case, was put together by the Center to Advance Palliative Care. I made some slight modifications that make her story a little bit more pertinent to here in Hawaii. And so I just wanted to acknowledge that, and also to highlight that there are many resources and organizations that are there to provide additional guidance and training for those who want to help in putting together and training a palliative care team. It's important to realize that for our CRUST patients, there are certain services that they already have access to. But what makes palliative care so important is the impact that people have in the lives of those who have serious illness. Quest already covers the basic needs of medical care, with everything from hospital services to lab services, as well as chronic disease management. But what the palliative care benefit does is add a team of specialized providers and services. Those services include care plan development and implementation that is aligned with the family and the patient themselves. The clinical services are provided through an interdisciplinary team that focus on the holistic needs of the patient and their family, and a focus on relieving pain and symptoms that are associated with their serious illness. On a longitudinal basis, it includes comprehensive management and, most importantly, care coordination and communication. The specific clinical services provided involve not only a physician, but a clinician specializing in palliative medicine, and also require the involvement of a registered nurse, licensed clinical social worker, and grief counselor. Other members of that team include other providers, nurses, CNAs, pharmacists, and all depend on the needs of the patient. But the most important for the patients is related to the access of care. Through this benefit, patients will be provided 24/7, 365 access. They will have a prescribing clinician visit with them at least on a quarterly basis, visits from interdisciplinary team members at least monthly, which can be done through telehealth or in person, a comprehensive initial assessment with reassessment every 6 months, bi-weekly interdisciplinary team meetings, and coordination with the plan on at least a quarterly basis. The comprehensive interdisciplinary assessment is to be completed within 4 weeks of the health plan's approval, with the focus being on person-centered planning and principles. It is an in-person assessment by the prescribing clinician and interdisciplinary team members. It aligns with the patient's needs and scheduled based on their preference. There is a social risk factor screening and care plan with overall management that is in alignment with current practice guidelines that may involve referrals for additional services. And then the final, most critical component to this benefit is the care coordination. With all that we've talked about that's involved, and not only doing the assessment, but putting all of these pieces together and how to best address and coordinate the individual's needs for someone with serious illness. That is why it's highly recommended that a lead coordinator be identified as the person who steers the team and ensures that the care plan is developed and implemented. Care coordination has to happen between all the key components that contribute to how to best take care of someone's serious illness. It includes the health plan, primary providers, case management, palliative care providers, and beyond. And why is that so important? It's the need for accountability. There's a need to understand the rules and responsibilities of each one of these entities. There needs to be good communication with the sharing of information so that everyone is on the same page. And this not only occurs with the day-to-day management, but also through any transition of care, including hospitalization or facility stay. The care coordinator is the keystone to making this an effective and successful benefit. I truly hope that this has given you a good perspective on the benefit as a whole and how it plays out in the lives of our patients. And with that, I'd like to say a big aloha and mahalo to everyone.
So today we're going to hear from Torrie Fields, the CEO of TFA Analytics, who is instrumental in the creation of this new benefit and is now working on implementation. Torrie serves as a strategic advisor to the Center to Advance Palliative Care, or CAPC, the Coalition to Transform Advanced Care, CTAC, and the Hawaii Department of Human Services MedQuest Division. Thank you, Torrie.
I'm Torrie Fields, and I am here today to talk about reimbursement under the new Community Palliative Care Benefit. And I will start by going through some of the essential contracting elements for the palliative care benefit, and then we will move into reimbursement, tactics, strategies, and how to do it. So first, the covered services include services that follow an interdisciplinary care plan and can be delivered in line with a person's goals. Providers who are delivering palliative care services should deliver care that reflects the culture of the member and ensures language preferences are addressed and met. As part of this new benefit, members have access to all of the other services and benefits available to them through Quest, which means that prescriptions and medical supplies, including durable medical equipment, are covered separately. And people can access home health and home and community-based services separately as well. So what is actually covered under the palliative care benefit then? First is care plan development and implementation of that care plan. Again, the care plan is a necessary critical component to ensure that the member and family and caregiver are kept at the center of their care, and that the care delivered by the palliative care team is in line with their goals for treatment. The care plan is coupled with a comprehensive assessment that utilizes validated tools, and any healthcare provider who can bill can actually bill for this comprehensive assessment to determine somebody's eligibility for interdisciplinary palliative care services. When we're talking about palliative care services under the benefit, these services must be delivered by an interdisciplinary team, and they need to address the holistic needs of the member and their family caregivers, focusing on relieving pain and symptoms associated with someone's serious illness. And availability to the care team must be 24/7, 365 days a year, as we anticipate that people will have symptoms or other problems that would need to be met outside of your standard 9 to 5 clinic day. A critical component of palliative care services includes comprehensive management, care coordination, and communication, including things like advanced care planning and goals of care discussions. So those are covered as part of the palliative care benefit as well. There are a number of contracting requirements when contracting to be a palliative care team or a palliative care provider through Quest. So I'm just going to go through a couple of those elements that can be found in the implementation memo. First, in order to receive a contract for palliative care services, a provider must have at least one employed prescribing clinician. So that could be a doctor, a DO, an NP, a PA, etc. You also must have at least one prescribing clinician with a specialty certification in hospice or palliative care. And that prescribing clinician with the certification can either be contracted or employed. So if you think about this, if your one employed prescribing clinician has a specialty certification in hospice or palliative care, you're checking both of those boxes off at once. The teams must have at least one physician delivering direct care and providing program oversight, so a doctor. And you must have an interdisciplinary team that include all of the required team members. The interdisciplinary team is not required to all be employed, so they can be contracted or employed, but they must be listed as part of that required team. While the requirements are that you must have at least one prescribing clinician with a specialty certification in hospice or palliative care, the entire team must have a training plan in place that includes the services required under the benefit, so pain and symptom management, goals of care, care coordination, palliative care, etc. And all of those staff who are either contracted or employed must have be listed as part of that training plan. Every member of the interdisciplinary palliative care team also must be registered with HOKU as a Medicaid provider. Note that some of the providers in that interdisciplinary team might actually not be a listed provider type in HOKU, so those providers would not need to be registered with HOKU at this time. All palliative care teams must have a licensed clinical social worker, so an LCSW, working with them. They can either be contracted or employed. And LCSWs can oversee other social workers like MSWs and child life specialists. Other required and optional members of the interdisciplinary team can either be contracted or employed, and they are not required to be full-time or required to be delivering care only to Quest members. We anticipate a lot of partnerships as part of this palliative care benefit. Please note that any billing clinician can be reimbursed for a palliative care assessment, but the providers who are reimbursed under the benefit as a palliative care team need to contract with the health plan to demonstrate that they are able to provide community palliative care services. And that is through a provider attestation form, as well as a contract directly with the health plan. So once you have a contract, how do you bill for these services? Well, just as an overview, the reimbursement structure has three components to it. The first is an assessment, the second is a bundled payment, and the third is a reassessment. Assessments and bundled payments are reimbursed to the provider entity that can coordinate all of the different services included in the bundle, in the palliative care bundled payment. The assessment, as I noted, can be reimbursed for any billing clinician, and you would use the HCPC code S0280 to designate that this assessment is for the palliative care program. We'll get into some of the additional details in a moment. The bundled payment is a monthly bundled payment rate that covers all of the services delivered through the interdisciplinary palliative care team. And you would use S0311 to designate that as the bundled payment for advanced illness or palliative care. Reassessments must also be completed at least semi-annually, and the code for the reassessment is S0281. And that will designate that it's the reassessment or maintenance of the care plan that was developed. For organizations who are facilities and are billing on a CMS 1450 or a UB04, you would also need to utilize the corresponding palliative care services revenue code. So let's get into some of the details here. The assessment and reassessment codes have a diagnosis code that is aligned with palliative care encounters. So usually you might see this diagnosis code in an inpatient palliative care team. And in order to be reimbursed for a palliative care assessment, you need to have this Z51.5 or a palliative care encounter listed on the claim. Note that it should be on the claim, but would not be used as a member's primary diagnosis. That primary diagnosis would be their serious illness. Providers who are billing on a CMS 1450 will need to use the revenue code in combination with the CPT code or the HCPC code. And there are codes that are included in the bundled payment that differ between Medicaid only and dually eligible members. You will find those specific codes within the bundled payment in the implementation memo, either on the Quest website or on the Kokuamau website. For services that are not covered by the codes included in the bundled payment, providers are still able to bill separately. So for example, if you are an LCSW on a palliative care team, you may have some of your palliative care services covered through the bundled payment, and you may continue to maintain your therapy practice for mental health services and bill separately for that. So please look at those codes that are included in the bundled payment to make the best determination about how you might bill under the bundle or separately. In the assessment, as I shared, any billing clinician can be reimbursed for a palliative care assessment. All members must be assessed for eligibility and submit documentation for authorization before billing for the bundled payment. It does, palliative care providers and billing clinicians can be reimbursed for these palliative care assessments, and it doesn't need to be the same organization that does the assessment that delivers the palliative care. We use a couple of different codes for this assessment. So the HCPC code is S0280, and that is the only code that you would need to bill when you're using a CMS 1500. For the CMS 1450, you would use that same code along with the 0693 revenue code that designates the assessment as a palliative care service. And again, on that claim for the assessment, you would need to use the diagnosis code of Z51.5, which is a palliative care encounter. An assessment can only be billed once per member, per provider, for each unique episode of care. So some individuals might have breaks between their use of the palliative care benefit. And so assessments can only be billed once per each individual episode. You will need to maintain documentation that the member meets eligibility criteria for palliative care and has consented to receiving services in order to continue on and enroll in the bundle. When talking about the palliative care bundled payment rate, that is reimbursement through a monthly bundled payment. So providers cannot be reimbursed more than one time per month for services, and you must deliver services by the interdisciplinary team during that month. So at least one visit by a member of the interdisciplinary team in order to bill for that bundled payment. Providers may be reimbursed in full for each month that a member is enrolled and receiving services, meaning that you wouldn't be prorated for somebody who enrolls in the middle of the month or disenrolls in the middle of the month. We use the code S0311 to designate the bundled payment rate. That is a monthly a reimbursement code for coordinating and managing an advanced illness. And for those who are billing on a CMS 1450, you would use the combination of S0311 and 0690 revenue code that designates that as palliative care services. Providers who are delivering care must not bill additional services a la carte that would be included as part of the bundled payment rate. So please check the memo to make sure that you're not duplicating billing as part of this bundle. On the reassessment, a member must be reassessed for services at least every 6 months or when someone's condition status changes, and reassessments cannot be reimbursed more than 1 time per month if somebody has a change in condition multiple times during their episode. The codes that you would use for the reassessment are S0281 for those billing under the CMS 1500. And for those billing under the CMS 1450, you would use a combination of S0281 and the 0693 revenue code that designates this as a palliative care service. On both types of claim forms, you would need to list the diagnosis code of Z51.5 to designate this reassessment as a palliative care encounter. MedQuest has developed some specific forms to help support providers and health plans through this effort. So we have 2 documents associated with care delivery. One is the eligibility assessment or screening tool that can be used by any billing clinician who is assessing a patient for palliative care need. And that can be turned in with supporting documentation to a health plan to start the palliative care bundled payment. Quest has also developed a care planning document that can be used to ensure that all of the required components of the care plan are documented and able to be shared as part of the interdisciplinary team meetings and health plan provider meetings. A third form is the Community Palliative Care Provider Attestation Form, and that is part of the contracting experience. In order to offer palliative care services, palliative care providers must first contract with a Quest Integration Health Plan. They need to complete an application for Community Palliative Care Services approval, and that is the provider attestation form. Once one health plan approves that palliative care provider attestation form, then this denotes acceptance by all the other health plans. You would still need to contract directly with the health plan in order to ensure that you're able to be reimbursed. The provider attestation form will go through periodic approval or renewal to make sure that providers continue to stay in compliance with the benefit expectations. And all members of the individual interdisciplinary team must register in HOKU in order to be accounted for and documented. Quest is also putting together a data and reporting plan and is contracting with the University of Hawaii to conduct a rapid cycle evaluation. And that rapid cycle evaluation will include the development of learning communities, rapid cycle assessments of the benefit utilization, and the development of an ongoing reporting and evaluation framework that will roll out in year 2 of the benefit. Until then, health plans will need to follow their existing program integrity responsibilities, including encounter data analysis, visit verification procedures, any recoupment of overpayments when the reimbursement expectations have not been met, compliance activities to ensure that providers are maintaining standards and expectations, and standard audit procedures. So for providers, please make sure that you keep your documentation about those who are enrolling in palliative care and that you are complying with audit expectations from the health plan that you're working with. There are more resources on the palliative care benefit in the memo on the MedQuest website, as well as on the webpage for Kokua Mau. And if you go to the Kokua Mau website, you'll find additional resources on palliative care that include patient-facing materials, determinations about how to know if palliative care is right for you, as well as palliative care resources for providers who might be delivering the palliative care or providing the assessment. Thank you.
Well, thank you very much to Toby and to Torrie. Really appreciate all that good information. What we're going to do now, folks, is we're going to start addressing some of the good questions that have come up. I'll just start at the beginning. I think maybe the first one goes to you, Toby. With this case study, since the patient lived alone, was there a social worker or other team members to look at the social isolation needs and additional community support in between visits made by the palliative care team?
So yeah, that's a key component to this case really is the social worker involvement. The hope is that social work assessment really does get the information about services that can be provided in support of that patient being able to stay home, to be as independent as possible. And then the palliative care team is really the hub to connecting all of those pieces together. And the social services piece is vital to making sure that isolation is being addressed, whether it's involvement with the community, with, as you saw, the senior center or the church, but also connecting with the health plan and addressing the services that are provided that can come into the home, in addition to the palliative care services that are the added layer of services that are going to be provided.
For social factors assessment, is there a specific tool or tools required or recommended to complete the assessment?
I can say that there isn't a tool that is required for the social risk factors assessment. Toby, what would you recommend?
So I think when we're looking at a social work assessment, again, that's why we have our social workers on our team, is to provide this comprehensive assessment. Eventually, we're going to have more forms available online to address this. And I think that process is a building process. We want it to be a comprehensive assessment. We want it to address all the factors that are important to the patients themselves. There isn't one specific tool that I would recommend right now, but I would say be on the look for future resources in that regard, because they are going to be developed, they are going to be implemented, and we are going to put them into play.
I have a client who seems to qualify for palliative care benefit, HMSA patient. How do I start this referral process? When are home health quest providers able to get their patients onto palliative care? Who do we call?
So yes, hot topic right now, right? How do we get access to this wonderful benefit? So I will tell you, we are early on, and as we develop this communication, this care coordination, part of our outreach is really to address the primary care providers and provide resources. And through Kokua Mau, that's going to be your biggest referral basis for resources and access to providers. Right now, our providers are in the process of getting credentialed with the payers. They are submitting their attestations and getting things set up. If they haven't been registered for Hoku, which I did see a question about, how do we register for Hoku? And that is through the MedQuest website. There is a provider enrollment website page that you go through the process of answering all the questions. You submit all the information to Hoku, and then after that, you follow up with your attestation with the payers themselves, and see where you're at in the process. So being that we're still in that phase of essentially credentialing, we don't have a list available right now. As that list develops, though, through Kukuamau, we want to provide that to you on the website and have that resource available. So primary care providers, home health, whoever needs access to this benefit and team will have access to a list of providers that will be doing this for their patients.
Okay, good. Torrie's nodding, so excellent. So next question is around, I mean, it's great to have so much enthusiasm, right? When we talk about 24/7 availability, are there criteria for what counts as availability? Does it mean someone needs to be on call? Would e-messaging systems count?
You know, the way that I think about 24/7 availability is that you need to be as available as a patient needs you to be. And so many with some anticipatory guidance and sort of the preventive service that you're providing as a palliative care provider, a lot of the things that come up as after hours issues can likely be managed by phone or by video or in being able to sort of triage things and not have to go into someone's home. There are certain circumstances, though, that might need to be the case. I would say that what we have seen is that it's a minority of those situations if you are sort of putting together the anticipatory guidance in the best way. But in that circumstance, I would recommend that you have someone on call for those situations where somebody might need to have a home visit. It does not mean that you need to be able to have a regularly scheduled appointment during an after hours time. Would you agree with that, Toby?
Yeah, for sure. I think the concept is that you have a patient that has something going on after hours and needs to be addressed right away. And there needs to be a system in place to provide guidance, an on-call nurse or somebody to help guide the decision-making process. As we go through this and we've got different degrees of severity of serious illness, there's going to be symptom management that needs to be addressed, but also just the logistics of what to do the next day or the following week and who needs to see the patient in their home versus set up a visit. So that coordination is going to be essential, and that access, I don't believe, can just be done through an e-messaging type of situation where if it's a non-urgent condition, sure, you can have that as a way to communicate, but there really needs to be access phone-wise to somebody who can provide guidance.
Great, thank you. So Torrie, can this be billed on an HCFA 1500?
Yes, the reimbursement can be billed on either a claim form 1500 or a claim form 1450. So you don't have to bill on a UB04, which is also known as the 1450. You can bill on the 1500. It really, what we tried to do is really align it with how you're billing today, and to make it so that both organizations like hospices and home care agencies are able to bill their regular route, which is the 1450, or individual provider groups can bill on the standard CMS 1500. So just look for the guidance that is based on the claim form that you are using as part of your regular practice.
For visits to a patient for each month the patient is on services, will telehealth or phone check-ins qualify as a regular visit by the LCSW? Some patients don't want or need a physical visit at home, depending on their goals of care.
Telehealth and or phone check-ins do qualify as regular visits, and especially by an LCSW who can do a lot of things remotely to help support somebody in resource coordination or in their behavioral health challenges.
Is a palliative care provider designated as the member's primary case manager required to use the MedQuest Health Function Assessment and Health Action Plan documents?
That is a great question. We are currently working on some additional components of the health function assessment and health action plan that will include the palliative care components in it. So that means that a care plan can actually then, the health action plan can be used as the care plan that we're requiring as part of this, with some of those additional palliative care features layered in, really working to make sure that this is a streamlined process so that that assessment and health action plan are those tools that you can use.
Yeah, there were a couple of questions about the forms. Obviously, people are excited and ready to get started. Did I miss what the payment ballpark for these services is?
You can find the rates for the fee schedule in the memo. So if you go on to the MedQuest website and you click on the memo, the rates are in there for each one of those specific HCPCS codes that we talked about today.
Is it expected a patient has a primary caregiver when admitted to palliative care service?
I'll take that one.
Thank you, Toby.
Sure. It's not a requirement to have a caregiver. The whole hope of this palliative care benefit is to have an added team come into the home and address the needs of the patient first and foremost. The caregiver sure is an added benefit to taking care of the patient, but it is not a requirement. It's not a requirement to have a caregiver. We want to address people who have serious illness early on in their course. Hopefully, it's prior to them needing a caregiver. Hopefully, we've assessed early on enough that we can help them if they need to find a caregiver, to get a caregiver for them, or access the health plan to see what kind of services that they can receive in their home. So really, there's no requirement on the caregiver side of things.
I missed one that several people asked about. Is pre-authorization required from the payer to provide service? Will the insurer need to review the initial assessment for approval?
Pre-authorization is not required, but is allowed by Quest. So the individual health plans may have different ways of doing this or prior authorization processes as part of this benefit. So as you're working to contract with the different health plans, that's something to sort of cover as part of your contracting discussions.
With a monthly payment structure, how will organizations implement checks and balances to ensure payments are consistently received? Based on HMSA's PMPM program, how it operates, sometimes patients drop off, resulting in missed payments for the month. Will you provide back payments for patients who were inadvertently excluded?
So, the intent is to pay for services based on the memo and reimbursement for those services. So the logistics of that, obviously with a new program getting up and running, we want to make it as streamlined as possible. I think that, the credentialing part and HOKU registration and things like that, all those things, the sooner the better they can get lined up so they're not hiccups along the way in being paid, would be what my recommendation would be, to make sure that it goes smoothly. But the payment is paid out as it is stated, and the timing of it, obviously we want to get providers paid as quickly as possible. But again, new program, we want to get this up and running as quickly as possible and also provide the support. So.
And one of the checks and balances that was built into this benefit is the regular check-ins between palliative care teams and the health plan teams. And so if there are any challenges in terms of patients dropping off a roster or there being gaps in visits during that time, et cetera, those are things that really can be part of the care coordination conversations between the health plan and the provider. So just a little bit of a stopgap there so that the health plans can get a better sense of when some of these things are happening.
How much flexibility is there in contracting with people who are non-HOKU providers? So does everyone who touched the patient have to be registered in HOKU?
So not everybody has to be registered in HOKU. What point of Hoku is that the provider themselves and those who submit billing have access to the billing process through the credentialing of each payer, right? So, part of the requirements are team members that don't register through Hoku. So the requirement in the memo is really in regards to the visits, the frequency, the interdisciplinary team that's involved, but that part is independent of the Hoku system and registering for payment and billing. So two separate issues of the team that's involved as opposed to the billing services that are associated with that.
Good. Okay, here's a good question about assessment. I know a lot of people are talking about this because it's such a great addition. If a referring physician completes and bills for an assessment of the patient before referring that patient to them, can we complete and bill for our own assessment of this patient? And this is coming from a palliative care entity, palliative care agency.
You can. An assessment is a critical component of the care planning process. And so you're going to get a better understanding of that patient, and perhaps a different understanding of that patient than perhaps the referring provider who is assessing the patient for eligibility. And so, if there are things that still need to be documented in terms of that assessment process so that you can develop out a care plan, you can be reimbursed for that assessment as well.
So here's an important point. Does this mean a patient will no longer be eligible for home health care if they get admitted into palliative service, just like hospice?
Home health is part of the standard benefits that Quest offers to Quest integration members. And so the home health is going to be something that is concurrent with palliative care services for those individuals who qualify or need home health services. So it's different from hospice in that palliative care is actually an extra layer of support on top of all of the other benefits that is available to the member.
Right, we're not giving anything up, you're just adding on. Do we drive this service to pay under Quest only, like home community-based services, or does palliative care claims pay under a member's primary insurance first? In other words, commercial or Medicare, and Quest as secondary?
This benefit is only for Quest members. You'd have to check with the other insurance companies, so the commercial or Medicare Advantage insurance companies, to see if they are also going to cover it. But it is intended only for the Quest primary members that we're talking about as part of this benefit series.
Can you define hospice or palliative trained as it pertains to physicians?
So I can address that. From the physician standpoint, board certification, the American Board of Medical Specialties provides hospice and palliative care board certification. There is also a certificate program for hospice that would qualify for additional training for physicians themselves. Each of the disciplines too, there are programs nationally through CAPC, through a lot of different organizations that provide certificates for a lot of the other providers, but specifically for physicians, board certification or certificate in hospice medical directorship meet the criteria for having the additional training that's necessary.
So just so folks know, there's a lot more questions in the chat that we're not going to get to today, but we're going to compile them all, share these with MedQuest, and they can be answered in the future. So one last thing, since we have this, it's an interesting question. Can you talk a little bit more about verbal consent as they are listed in the memo?
Why don't you go first? I'll add to what you have to say.
Oh, that's funny. Ultimately, this is not something where people are auto-enrolled. You do need to assess somebody for eligibility and offer them palliative care services, and that consent would be verbal. It's them accepting that they want palliative care to be added as part of their the services that they receive. There are some situations in other parts of the country where people get auto-enrolled in things like palliative care, and that's just not how this benefit works. People need to be, knowledgeable about signing up for it and receiving it.
And I would
Great.
just add, there's no election process. Verbal consent is by the patient themselves or the decision maker themselves. Those are, and it's through this should be geared through coordination with the primary care provider. This is meant to be a care coordination across these different disciplines and as a team. And so essentially that consent should be supported by the primary care provider as well as the patient and the patient's family.
We have come to the end of our time. As I mentioned, there still are a bunch of questions, so we will be compiling the questions, forwarding it on to MedQuest. People can also contact MedQuest directly with their questions. As we did last time, if people would like a copy of Torrie or Toby's slides, you can send an email to me at info@kakuamau.org, and I can forward that on to you. Reminder to folks, the next webinar is Tuesday, and that is the palliative care pediatric benefit. So we hope that folks will join us on Tuesday. And then the final session is on April 3rd, which is for the public. And we hope people will also encourage their patients as well as anybody that needs to learn about palliative care to attend. I want to thank the audience for attending, these excellent questions, the engagement. Clearly, people are very excited. Thank you to Toby and Torrie for your time. As Toby said, we're in this together, we're learning, and it's very exciting. Otherwise, mahalo. Thank you so much for coming.